our first webinar as for a journal club presentation. The article that I have taken is was accepted for publication in Cardiovascular and Thoracic Anesthesia. The topic of which is cardiac risk of non-cardiac surgery after percutaneous coronary intervention (PCI) with second generation drug-eluting stents. Stress being on the second generation. All right, my presentation will include some background just to explain those who don't know the whole story of why we are doing all these interventions, relevant previous guidelines, and why there is a disparity amongst them, justifying the study design, results, discussions which will include my interpretations, the limitations of the study, and conclusion. All right, so a bit about the background. 1977, I believe, was the first balloon angioplasty done in a live human, uh, which was a really big step in cardiology. The only problem was after a balloon angioplasty opens up a coronary vessel, the chances of it collapsing back is unpredictable and high. So they thought, all right, why don't we use a stent to keep the coronary vessel open? The first stent was introduced in 1986 as a bare metal stent, which was also a good idea. So the bare metal stent keeps it open after the coronary angioplasty. However, because there is a foreign body, there were high chances of stent thrombosis because all that bare metal is exposed to the blood and you have thrombosis forming around it. So then they introduced, all right, let's do a dual antiplatelet therapy, which will help prevent the thrombosis for the bare metal stent. That was also good. However, after a certain duration, there was something called an in-stent stenosis, restenosis actually, which basically means that although there's no thrombosis forming, because we have done a little bit of trauma to that part of the coronary vessel, there will be hyperproliferation of tissue, which will cause stenosis. So again, we come back to that it was fine to start with for the coronary vessel, but later on, the chances of it again collapsing or again getting blocked were high. Therefore, drug-eluting stents were introduced, which is basically a stent with a drug that will have an anti-proliferative agent, details of which I'll just show you. And this drug-eluting stent has actually evolved into a second generation and third generation stents. And this study was basically to demonstrate what are the cardiac events what is the incidence of cardiac events that can happen after a newer second generation drug-eluting stent is put in when a non-cardiac surgery is done in that same patient. Briefly about drug-eluting stents. So again, these are bare metal stents. They have a polymer. First generation used to have a thick polymer, which was pro-inflammatory. It used to have a profile where the drug, the antiproliferative drug, which is sirolimus and paclitaxel, that gets eluted quite quickly. So you're losing out on all the antiproliferative agent properties very quickly. Hence, there were high chances of late or very late stenosis. Then they've improved on it with the second generation stent. All right. So for our benefit, and from all the inquiries that I've made from Basildon, we use three types of stents. One is Zynes 5, as you can see, it's a second generation stent with everolimus. We use Resolute or Onyx, and we also use Synergy. They've actually advanced on the second generation stents with new biodegradable polymers, and they have special drugs with special stents which just inactivate the luminal side. All these are advances. All these are advances with this in mind that we don't want the late complications of stenosis, and we don't want to use a lot of dual antiplatelet therapy, which has its own limitations. Now, a bit more about Zymes 5. This is the drug-eluting stent that was used in this study. It's an everolimus eluting stent. The way it works is, and this is for your understanding, 25% of the drug goes out within 24 hours, and the rest over the next 4 months, which means that after 4 months, this stent behaves just like a bare metal stent. It gets endothelialized, and then after there is an endothelium that covers the whole stent, you don't really need dual antiplatelet therapy. With this in mind, there have been a lot of guidelines published in the American, in by AHA, by Canadian journals, by European journals, and I just want to tell you a bit more about these guidelines. Now, these are pertaining the duration of dual antiplatelet therapy that we need to strictly follow after a stent is placed. And when I say strictly follow, I mean obviously in an emergency you need to do the emergency surgery, but they had proposed that all elective surgeries must be postponed for this duration. Uh, first and foremost, the 2014 guidelines, American AHA guidelines. It basically said that after a drug-eluting stent, you have to wait for 1 year, 365 days. In the same year, European guidelines came out, which actually noticed, or which actually recognized the difference between the first and second generation drug-eluting stents, saying second generation or third generation just needs 6 months of strict coverage. There's been an update in 2017, which is quite which is recent, which says that theoretically, or which says that according to its research, you only need coverage for 1 month. That's it. So you only need strict coverage for 1 month. After 1 month, it says continue the aspirin, and you can still get the surgery done. Now, as you can see, there is a lot of differences in timelines, and this study is trying to see the cardiac events that can happen in terms of these timelines. The Canadian the Canadian guidelines, the interesting thing that I found there was it did agree with European guidelines saying 3 to 12 months, depending on the drug-eluting stent generation. It also said about aspirin that there have been a lot of studies which say that you should not start aspirin just to prevent perioperative complications, as was previously thought, except when you're using a stent, or very strong evidence is when the patient is undergoing carotid endarterectomy. It's just something that I picked up, which seems relevant. All right. Basic study design is that it's a retrospective study, which they included patients for over 3 years. They recruited all the patients who gave consent, who had a second generation Zymes 5 drug-eluting stent put in them and had a non-cardiac surgery. Definitions, they are basically checking the cardiac events. So MACE is major adverse cardiac event, and defined as a myocardial infarction, stent thrombosis, requirement of revascularization within 24 hours, and a 30-day all-cause mortality. They've also defined excessive surgical bleeding, just to see the impact of that. Based on these guidelines, they decided to divide the patient subsets into surgeries happening in the first 3 months after the drug-eluting stent is put in, surgery happening from 3 months to 6 months, 6 to 12 months, and more than a year. Just to see how valid are the recommendations of within 6 months, within 3 months, etc. just to compress the results into what seems relevant. 282 patients, mostly males, were recruited. The total major cardiac event incidence was 5.3% overall. The statistically significant results that they could find was that within 90 days, there is a very high chance of you getting cardiac events. After that, there is no statistical significance in you getting a cardiac event after the drug eluting stent was put in. So they were going towards the 3 months. They have said that on observation, you as you can see, you have a higher incidence within 180 days, but they've just mentioned statistical significance in the first 90 days. On the bleeding aspect of it, the total excessive bleeding that they could find in these patients was 6.7%. Again, they did find in numbers that the choice of antiplatelets and the duration from surgery did make a difference, but this specific thing, if you look closely, is not statistically different, which basically means that either they need a higher number to actually ascertain what is the bleeding risk, or there may actually not be a difference in antiplatelets or when to stop the antiplatelet therapy before surgery. In their discussion, they've compared their studies with various other studies. The interesting that they found was when compared to retrospective studies, they found that their numbers almost always matched. So their major adverse cardiac events risk was matching in with many of the studies and the bleeding risk. However, the major difference was when they compared their studies to prospective studies. And they always found that prospective studies had a higher incidence of cardiac events registered. Now, why is that? One of the studies, they included more in their MACE definition. When I say more, apart from the MI and the 30-day mortality, they also included cerebrovascular events in their MACE. So anyways, you have more events, you will have a bigger MACE. The other study, which is interesting, which was published in British Journal of Anesthesia in 2016, actually had a protocol for every patient to do a troponin T or troponins and ECG after their surgery, no matter what their clinical picture was. So they didn't wait for chest pain or hemodynamic instability. They just did it for all patients, and they found that we are missing a lot of our NSTEMIs, which is really interesting. So and hence they had a higher incidence. They had about 20% incidence of MACE. 20%. A very old study when we didn't have any guidelines and we never used to delay surgeries after drug-eluting stents, had actually reported a 47% incidence of major cardiac events. So we have improved from then. Definitely we have improved. It's just trying to find out what is the best time without compromising on when the patient can have the elective surgery. My interpretations. The study does agree with 3 months of antiplatelet therapy being strict. Although very interesting is that the newest update, 2017 update of European update, says do it just for 1 month. It actually also gives you a way out if you want to get the surgery done within 1 month, saying that use infusions of eftilfubate or tirfeban as bridging if you have to get it done within a month. But it strongly recommends for 1 month, keep the patient on dual antiplatelet therapy. There is an increased risk of cardiac events within the first 180 days, right? Again, in keeping with many of these guidelines. There is a higher incidence of dual antiplatelet therapy when not using it, although they have determined that you need a very large observational study to actually determine exactly how much risk is with aspirin, without aspirin, with the dual antiplatelet therapy being continued within 7 days. Uh, and all these studies, all the guidelines, there's one common theme. You need a multidisciplinary decision making team. So you need the cardiologist involved and the surgical team involved and the consultant anesthetist saying, do we think that stopping the dual antiplatelet therapy is worth the risk? It should not be a we can't do any surgery in this patient. We need, it is a difficult decision, but we need to make this decision. Uh, the other very important observation that I had was in one of the studies, they actually compared what are the risk factors for MACE after putting a drug-eluting stent. And they found not the type of stent, not the duration of antiplatelets or what antiplatelets you're using. It is the surgery itself. So emergency surgery will always have a higher degree of cardiac events. So, and that's something that we need to do. And as I've already told you, we may be missing a lot of type 2 or non-STEMIs in our patients. Again, I'm not saying that it justifies using a protocol for troponins and ECG post-operatively, but it's an interesting thing to find. All right, limitations of the study. It's a retrospective study, so any charts that were missing, any patients data that was not there, if they were followed up in a different center, they were not included, so they didn't include a lot of patients. Again, they didn't have a protocol. So all these studies, they are defining MACE differently. They're defining how excessive bleeding is different. So it's just really difficult to compare all of them. The sample size was low, so the only statistically significant result was less than 90 days you have increased cardiac events with single center trial. All right. So again, coming back to my conclusion, we know that major adverse cardiac events incidence was 5.3%, similar to what first generation drug-eluting stents had. And the maximum incidence seems to be in 90 to 180 days. We definitely need, or we definitely require for a better understanding of the exact risk factors why cardiac events happen after non-cardiac surgery, probably by a multi-center prospective registry. The optimum window, we still don't know, but I think are getting there. We are progressing to understand whether it's 3 months, 6 months. We understand the need for individual assessment, and we need to exactly clarify the perioperative antiplatelet therapy. Should we continue aspirin, not continue aspirin, exactly what to do. Thank you. Any questions?
That was excellent, and thanks for giving such a good background as well.
Yeah, it's interesting.
With the history and the way it's evolved. Any questions?
One question is with regards to the Canadian study. What is the level of evidence?
So
Because most of the guidelines will tell you exactly whether it's 2A, 2B, 1, etc. The ECS guidelines are very specific with regards to, they are actually 2A with regards to the duration. Whether is that actually better than that? Is that a recommendation, or is it just weight of evidence is in favor or not?
So with respect to the aspirin part, this recommendation is copied from the guidelines. So it specifically says strong recommendations, high quality of evidence. Doesn't use the terminologies.
Maybe it will be there in the full paper.
Probably, but it just says strong recommendations for not to start aspirin if you don't have a proper indication, and proper indications can include the carotid endarterectomy and the use of stent. And we are talking about stents, so that's why I thought it was quite relevant here to continue aspirin.
The paper in the BJA, was that the Daniel Sessler paper that they measured the proposals?
So it's Vascovitz.
Right. Okay. What was the population group on that? Did you look?
So about 201 patients were
Right.
used, and it was again a single center study. I think over 2 years. I'm a little fuzzy on the details, but the main aim of their study was just to find out the risk factors. So they actually divided all the risk factors in what is the Lee cardiac index for getting cardiac events after in this scenario, or what was the uh, emergency surgery versus non-emergency surgery, what type of surgery it was, what is the patient characters, and the ACA of the patient, etc.
Brilliant. Any other questions? None. Great. Well done.